Welcome, everybody. Welcome. My name is Cathie Sudlow. For those of you who haven't met me before, but hopefully many of you have now either met me in person or seen me kind of parading myself around in these kind of events, of which we have many. So I'm the director of the Usher Institute and head of the newly established School of Population Health Sciences in the College of Medicine here at the university. It's really a delight and a pleasure to welcome everyone here. There are many of us in the room, but also quite a number of people joining us online, so welcome to those of you watching online as well. It's also, what a treat to be in such a wonderful building. It's a long time since I've been here in the McEwen Hall and haven't been in here since the refurb. So for those of you who, like me, haven't been in here or haven't been in here very much, I encourage you to look around you, forward, but also up at the fantastic ceiling above you, because it's really quite a sight. So a little bit about the Usher Institute, because of course today we are celebrating the Usher Institute with our annual lecture. So it's 123 years since the Usher Institute was first founded, and as you know, it was reborn back in about 2017. But it first came into being in 1902 on the back of a philanthropic donation from Sir John Usher and Andrew Bruce. And there's a bit of an alcohol theme running through this because, as you probably know, they made their money through whiskey and beer, so distillery and brewing is a bit of a theme. And it's fantastic to welcome Richard Usher, who is one of the members of the Usher family, who has also attended some of our other events earlier in the year. The Usher Institute now is located in a fabulous new building at the Edinburgh Bioquarter, and the building is fantastic. Many of you are using it now on a day-to-day basis, and many of you will have been there when we opened the building officially in June of this year, when it was a great delight to welcome Dr. Tedros Ghebreyesus, who's the director of the WHO, to declare the building open, along with local MP and MSPs as well. So today it's our 9th annual lecture, and we have a long line now, an increasingly long line of distinguished annual lecturers, including John Ioannidis, David Blumenthal, Chris Whitty, Victor Zhao, Jeannie Shoveler, Martin Landry, Fiona Godley, and Susan Hopkins. And this year, we're absolutely delighted to welcome Dr. David Nash, who's the founding Dean Emeritus of the Thomas Jefferson University, to deliver the keynote lecture. We are also delighted to welcome David's wife, Dr. Esther Nash, who's joined David here for his trip. And this is their first trip to Scotland, and I'm pleased that they are taking a few days. They had a few days before this to settle in and have a look around Edinburgh, including a whistle-stop tour by Brian McKinstry, where they were struggling to keep up, but had an absolutely fantastic time. And they are also now going to, after this event, take advantage of being here and take a trip over to Glasgow and have a look around the Highlands. And then they're going to have to come back because they'll have seen just the beginnings of what Scotland has to offer, and they'll have to come back to see the islands and all the rest of it. So a bit of background on this fantastic venue that we're in today, the McEwen Hall. An extension of the alcohol theme in that the McEwen Hall was presented to the university in 1897 by William McEwen, who, of course, you'll know as a local brewer, but also a politician. And the cost at the time was £115,000. So it's gone up in value a little bit since then, and also has gone up in value since it was refurbished. So there was a multi-million-pound refurbishment in over several years in the run-up to 2017, which was when this wonderful venue was reopened. So as I said earlier, do take a look around you because it's quite cool. So it's wonderful to see so many of you here today, many, of course, from the Usher Institute, but many from across the wider university community as well. Colleagues here as well from NHS Lothian, from the City of Edinburgh Council, from Heriot-Watt University, and from further afield across Scotland and from England and elsewhere across the UK as well. A particular welcome to Professor Leslie Holdsworth, who's a member of our External Advisory Board, who's here today as well. I hope that those of you who are here have had a chance already to have a look at the showcase downstairs, to see the breadth of work that goes on across the Institute. You don't see all of it, but you see a fair spread. And there's some lovely work on display down there, and thanks to those of you who've contributed to the showcase. The showcase is available to those of you joining online as well. So if you go online onto our website, you can see all the posters visually and the summaries of all the showcase content on display, some of the videos as well online, so that you're not missing out at all. You can also log on using the QR code, which I think is now showing behind me, yes, on the slide, so that you can see all the features of the event on our website. For those of you both in the hall and online, there will be opportunities during the course of today to take part in a Q&A session, but to make it entirely egalitarian, irrespective of whether you're here with us or online, we're going to use Slido, so do familiarize yourself with Slido. Take a picture of the QR code there, and you can use that to submit your questions during the Q&A sessions. Think about your questions during the talks and stick them in, because once they're in, they're more likely to get asked. You'll also find the program and information of our showcase presenters by using those codes. So I need to tell you that there's no planned fire alarm today. So if there is a fire alarm, it's because there really is a fire, or there really is a fire alarm anyway. And in that situation, fire stewards will direct you to the nearest exit. So that's all from me. It now gives me great pleasure to introduce my colleague, Professor Linda Bauld, who, as you will know, is co-director of the Centre for Population Health Science in the Usher Institute, and also the Bruce and John Usher Professor of Public Health. Linda is also Chief Social Policy Advisor to the Scottish Government, and Linda is going to chair the session of our 4 presenters from the Usher. Thanks, Linda.
Well, a very warm welcome from me also, and to all the colleagues who are online. So it's just delightful to have another Usher showcase and annual lecture. I'm really looking forward to hearing from Dr. Nash. So I have the privilege now of introducing 4 fantastic colleagues. Many of you will know that we are a vibrant research institute, and we have 4 centres and a clinical trials unit in Usher. We have the Centre for Population Health Sciences, for Biomedicine, Self and Society, Medical Informatics, and Global Health. And I'm really delighted that the 4 presenters we have today come from each of those 4 centres, but of course not forgetting the Clinical Trials Unit, who do just fantastic work supporting trials, not just here in Edinburgh, but around the country and globally. So as Cathie was saying, please listen to the presenters and submit your questions on Slido, and then we only have a short time for the Q&A, but I will choose a couple of questions to ask colleagues. And if your question doesn't get answered, I do know that our 4 presenters will be around afterwards in the poster area, etc., and you can perhaps engage them in conversation then and ask them about their research. So I'm going to introduce the first speaker now, and I'm really delighted to introduce Dr. Ahmar Shah, who's going to talk about backlogs, bottlenecks, and the uneven road to recovery. And he is a senior research fellow in Usher and also our director of innovation. Ahmar.
Thank you, Linda. So I'd like to begin by, just for the next slide, to take you back to the early days of the pandemic in 2020. So just for this one slide. When the pandemic happened, so for very obvious reasons, the finite resources, they were diverted to respond to the COVID-19 emergency. And we had our first lockdown, which at the time was unprecedented in the kind of country we live in. And the initial concern back then was, what would be the impact of these measures on the provision of healthcare for conditions other than COVID-19? So this is one of the pioneering study that we undertook, where we started looking in detail into the impact of the lockdown, but also once the restrictions were lifted. And we did this from data from NHS England, NHS Scotland, and Wales. And we looked at, so the period that we had before the pandemic, we used that as a control. The study is what's called interrupted time series analysis. And some of the key findings that we found, first of all, there was an obvious drop in the total admissions, both scheduled care, unscheduled care. And then the worrying thing was that even, which at the time looked quite longer, several months after the initial restrictions were lifted, we had not been able to restore the pre-pandemic capacity. And what was also very concerning was that the deprived and ethnic minority, those groups were most affected. So as time progressed, we started seeing this backlog creeping up. And then there were some really, really important questions that needed answering for policy. So questions like, how big is the pandemic? How much capacity is needed to address this, how big is the backlog? How much capacity is needed to address that backlog? And what would happen if you do nothing? Or and when will it peak? And there was also concern that because of disruption, there would be people who might not have come forward. So how many are missing? And what would it mean for those who return? What would it mean for the overall healthcare system? So these are the kind of questions that are not just relevant back when the pandemic, but they are also going to be relevant in the future. So we took a sequence of studies, and I'm just going to briefly talk about two key studies that we have published. So we started looking at the data from NHS England, so data from all the way several years before pandemic, starting from 2012. And from that data, we used that data and developed a model using this class of techniques, what we call machine learning, to understand the relationship between the waiting list, the demand, and the capacity. And once we had that model built, then we used that to make projections for 3 years into the future, and then we came up with different scenarios of what would the peak be like if the capacity is increased by a certain percentage, etc. And some of the key findings when we did this study, so we did this in England, then we also did a more detailed study in Scotland, looking at different specialties, looking at different regions. And so some of the key findings. First off, the backlog pressure that we see, it did not begin in the pandemic. We already had a problem. The pandemic just exacerbated an existing problem. And also, because we had this study after a while, the second study, a more detailed study, so we also got an opportunity to look at some of the initial announcements and the recovery plans that were announced, and we could see the difference between whatever was planned and what was actually achieved. And the conclusion was that the recovery efforts, they had really fallen short of what was announced. So the suggestion is, obviously we need a sustained capacity increase. It would be needed for several years for recovery, and also there needs to be more realistic planning. And what made me content personally was that the findings from this, they were not confined to just published papers. The findings from this were extensively covered by media, including front pages of some national newspapers. They were covered in BBC, STV, in radio, etc. The findings from this were also shared with senior policymakers, chief medical officers, chief scientific officers. They were also discussed in the parliament. And personally for me, when I see the findings from data like this, so there's a lot of knowledge when you see the data, but the resilience, it comes from acting on that knowledge. And for us to be better prepared for the next pandemic, we have to make sure that the system we develop, that not only is capable of surviving the shock, but is also able to recover faster and fairer for everyone. Thank you.
Our next speaker is Dr. Nicola Boydell, who's a lecturer in social science and health. Thank you, Nicola.
It's a real pleasure today to be with you all and to share some of the work that myself and my colleagues, the amazing team that I work with, have been doing. When it comes to abortion and contraception, not everyone in Scotland is starting from the same place. The COVID-19 pandemic widened inequalities, and understanding and addressing them is at the centre of the work that we want to share with you today. The COVID-19 reshaped abortion care and contraceptive care in Scotland, the UK, and globally. In Great Britain, changes to the law on where the treatment could take place, alongside the rapid provision of telemedicine care, made early medical abortion more flexible and better aligned with the needs for privacy that were expressed by many abortion havers. But the move away from routine care and in-person consultations made it harder to access some forms of contraception after abortion treatment, especially ones that are long-acting and require a healthcare professional to fit. More broadly, contraception has become much more difficult to access since the pandemic, and that, in combination with changing patterns of contraceptive use, has rendered post-abortion contraception a pressing public health issue for policymakers. Our research conducted before, during, and after the pandemic shows that inequalities in access to post-abortion contraception are persistent. They don't affect everyone equally. Evidence shows that young people, those experiencing socioeconomic deprivation, rural communities, and people from minoritized racial and ethnic groups are disproportionately affected by inequalities. And that's why, with funding from the Scottish Government, we developed the SCOPE project. That means service co-design to enhance post-abortion contraceptive access in Scotland. From the start of this project, our aim has been to work with community organisations, community-based organisations, people who provide abortion, to understand the priorities and to co-design models that better reflect people's needs. In the SCOPE project, we used a participatory approach underpinned by principles of experience-based co-design. And this is an approach that's widely used and implemented in healthcare, but the evidence shows not in abortion care. And that's because of the stigma and the routine politicisation of reproductive health, which often limits the participation of those most affected in shaping research and services. So we brought together people who had experience of using services, as well as those who provide it, and they were partners in the project. So we synthesised the evidence, we ran a series of workshops to co-design with our partners models of care that might work better. But importantly, the process didn't just generate service model ideas. It allowed us to reimagine care in a way that is inclusive, flexible, and grounded in the needs of communities, while taking into account the systemic inequalities and the barriers that continue to shape access to abortion and contraception. And in many ways, the process itself was transformative. We sought to centre the experience and community expertise and acknowledge and work within the limits that we know exist and the barriers that exist within NHS-delivered abortion care to surface what good post-abortion contraception can look like and arguably what it should look like. So at the start of this month, we shared findings from our project with collaborators and community people, community expertise from the key phases of our project. And we brought together people from the UK, Australia, Canada, and Sweden. And together we spent some time trying to co-design and develop recommendations to support the use of these models, these flexible models, that can, in a way that can respond to the changing UK legal context and healthcare. And importantly, we reached consensus around a key issue. That is, If we prioritize and center the needs of those most excluded and minoritized, excluded from healthcare systems, we can more effectively implement approaches that will meet the needs of people and that will be just, fair, and sustainable for both those seeking and providing care. For us as a team, a key lesson from our SCOPE project is not just about finding one model or an ideal way to deliver care. It's about embedding equity, about embedding flexibility and reproductive justice into post-abortion contraception. Principles that can guide work here and that resonate globally at a time of increasing hostility towards reproductive rights and justice.
And our next speaker is Dr. Gwenetta Curry, who's a reader in Race, Ethnicity, and Health.
Hello. It is a pleasure to be with everyone today, and I'm often not this tall on the stand, so I appreciate the step. A long way from home, the impact of COVID-19 policies on refugee and asylum seekers in Scotland, a systematic review. I thought long and hard about this title because often titles are what grabs your attention. But the first part about a long way from home really drives home the message that people come far and wide to the UK for various reasons. And during the pandemic, this was something that happened and it disproportionately affected certain people versus others. And during the pandemic, there was a lot of conversation around, we were all in this together, right? That was the thing that was just drawing everybody in, we're all in this together. But as the data came out, it became very clear that certain groups were impacted disproportionately than others. I would like to start off with just acknowledging my team. As you do this type of work, you don't work alone. And I'm a part of an amazing team led by Ruth McQuillan, who's sitting in the back, and Evie Teodoro. And this is a picture here from the Impact Festival, where we were recognized for excellence in teen culture. And it has been a pleasure to be a part of this team. And everyone's not in this picture, but some of the key members are here. And Emily is sitting here as well. I would like to acknowledge that she also helped manage, uncover, and was a key proponent of this research. So what we decided to do with this, it was a direct response to the Scottish COVID-19 inquiry. And we examined how the public response impacted refugee and asylum seekers during the pandemic. And we focus on how do they have access to PPE, as well as financial resources and support. We looked at the ability to shield or lock down. We know that policies were put in place broadly to tell everyone to stay at home. What did that mean for refugees and asylum seekers? Also, lastly, vaccinations. When vaccines finally came onto the scene, who had access? What were the barriers to gaining access to that? And what did that mean for refugee and asylum seekers? So we decided to conduct a systematic review. And this is the PRISMA diagram. And we use peer-reviewed research as well as gray literature. As we know, there were a lot of challenges during the pandemic on gathering evidence because papers were coming out very quickly. There was a lot of things in preprint. But for this, we use gray literature as well as peer-reviewed research. And we came down to including 49 papers in our finished product. And so this is our findings. So what we found is that changes during the pandemic had a disproportionate impact on COVID-19, the accommodations and changes. So there were accommodations set for asylum seekers and refugees prior to the pandemic. Well, there were changes that were made that actually disadvantaged this group. And so those were things that disadvantaged them and caused actually greater harm. So not only access issues around housing, but also financial situations. So how are you to gain access to proper PPE? How are you supposed to eat if you have extra restrictions? So these were some of the challenges and what the evidence demonstrated. Also, if you think about refugees and asylum seekers and why they left their home countries, they were already in distress. And the lockdown conditions exacerbated the mental health of this group. And that's what the data showed. And so these communities continue to struggle to not only gain access to mental health resources, but also to exist within their homes, and what did it mean to, stay locked down with lack of resources. Fear and mistrust. This is something that was, at a headline of, a lot of the data, because if you fear to engage the system, how are you going to access health care? And when we're talking about protecting everyone in society, vaccines were the #1 kind of safeguard that we were pushing. But what people were finding is when they were trying to turn up for the vaccines, they were asked for information like, what's your address? And if you're a refugee and asylum seeker and your residence status may be precarious, you don't feel comfortable engaging. So these were some of the barriers, as well as language. Language barriers still persisted, and so it created a gap between access to quality health care. And I would just like to say that these barriers existed prior to the pandemic. It was just exacerbated by it. Thank you.
Thank you very much, Gwenetta. That was excellent. So our final speaker, and then we'll turn to the Q&A after that, is Dr. Luke Daines. Luke is a senior clinical research fellow, a data scientist. Thank you very much. And also a GP. Over to you, Luke.
Thank you very much, Linda. Breathless, exhausted, and life redefined. Long COVID touched many people's lives, individuals, families, and communities. Today, I'm delighted to share with you some of the work that we did in 2 projects from EVE 2 and FOSS, 2 cohort studies from the UK, which helped to explore long COVID. To begin with, I want to introduce you to Ash. She was one of 3 people with lived experience of long COVID who formed part of the patient and public involvement group who informed our research throughout. Every aspect of her life had been affected. She had to give up her job. She had to use a wheelchair to spend time with her family and go to the park. There were lots of questions around long COVID at this time. The 2 that I'm going to answer today are: what are the risk factors for long COVID developing? And secondly, what are the risk factors for breathlessness persisting after COVID-19? To answer the first question, we used data from the entire adult population of Scotland. We used routinely collected data. Those are data which are collected during healthcare interactions from hospital, prescribing, laboratory tests, and also from GP practices. One of the problems that we encountered, however, was that as a new condition, long COVID was poorly coded, and that's the way that researchers mostly look at routinely collected data. To deal with this, we were able for the first time to interrogate the free text from health records in a secure and private way, and this enabled us to identify more instances of long COVID than had we just used coded data alone. This resulted in us having 4 measures for long COVID available from health records, and these were the measures that we used to identify who had long COVID in our data set. And to answer the question what the risk factors for long COVID are, we used prediction modeling with some machine learning added in. We found that when we applied this to 1.1 million people who tested positive for COVID, there was an increased risk of long COVID if you were female, with increasing age up to 52 years, people that lived in the most deprived communities, people who are overweight or obese, those with respiratory conditions such as asthma and COPD, type 1 and type 2 diabetes, and also those people who've been hospitalized for COVID. In contrast, those with reduced association with long COVID were people who had been vaccinated and those who had an acute infection for COVID under the Delta or Omicron variants. So what about breathlessness after COVID-19? To answer these questions, we needed a different study design, and the FOSP COVID cohort was a multi-center study recruiting patients from 54 hospitals across the UK. We collected data from before hospitalization, during the admission, and also after the hospitalization. We used laboratory tests, lung function tests, questionnaires, and imaging. Those most at risk of breathlessness after a COVID infection in the 5 to 8 months afterwards were people who are female, again, those from most deprived socioeconomic communities, people who had depression or anxiety, and those with a longer hospital duration. In contrast, people who are older age groups above the age of 70 were less likely to have post-COVID breathlessness, and also those with black ethnicity. It's been really exciting to work together as part of two big research groups, to answer questions with improved understanding of risk factors which fed directly to Scottish Government and also to policymakers. But actually being in touch with Ash again this week has really reiterated to me that there is still a great deal to do. She's still not working. She's not able to access the treatments that she needs, and her life has been redefined. And so I'm hoping that we can still progress in this field. Thank you.
Well, thank you to our four presenters. You can see some fantastic examples there of multi-method, different disciplines being represented, and different approaches to research in relation to that period that we went through and the lessons that we're trying to learn from it. So thank you to those of you who popped in questions into Slido. Gwenetta, we're going to start with a question to you, and if we can keep the responses quite brief, because we obviously are a little bit tight for time. So Gwenetta, in doing that systematic review, but also in terms of your wider knowledge on the issues, did you look for and find any reports of homelessness amongst asylum seekers and refugees during the pandemic in Scotland? Thanks.
In this particular systematic review, we didn't focus on homelessness, but we did look at, accommodations and the precarity of those situations. So yes, asylum seekers and refugees during the pandemic were forced into kind of hotel accommodations during that time, and they weren't always the best suited for families.
Thank you. And we know we had at least one very high profile case relating to that. So thanks for that excellent question. Ahmar, how do you decouple the backlog from the lockdown itself, reducing some conditions and diseases, so people were less likely to have infectious diseases of other sorts, for example, during the pandemic, rather than decoupling that issue from the backlog? In other words, the question is theorizing that there would have been fewer patients in hospital because of the lockdown, potentially, and people not picking up other infectious diseases. So is that a feature that you looked at in the study?
So when we looked at the overall lockdown, because the overall lockdown, the numbers are huge, so the significant proportion would be people waiting. So this is about elective care. And elective care means that these are patients that have been, a decision has been made that they need to be, so they were referred, they need to be seen, but they're waiting to be seen. So this would be independent of people who might have had a positive impact because of less social interaction, etc. So yeah, by definition, those on the waiting list means that they are someone who have been decided that they need to be seen and they're still waiting to be seen by a consultant.
Thank you, really valuable work. And Nicola, a question here, should the easier access methods for contraception that were enacted during COVID-19 also be deployed after the pandemic?
So telemedicine access to abortion care has continued since the pandemic, and actually the work that we did in one of the papers that's described here, demonstrated and was taken up, the evidence was taken up by Scottish Government to continue access to telemedicine abortion after the pandemic. But I think more broadly, some of the work that's come out of our project has really highlighted the need for rethinking the abortion contraception continuum and to really think about what it means, what legal changes could mean for access to contraception across the life course for people who need it. Different things work for different bodies, for different people, for different communities, and I think that we need to think about contraception differently and make that much more accessible than it currently is.
Thank you, Nicola. So, Luke, I have one question for you, and then we've got an excellent question for the whole panel that I'll ask you to reflect on, because we do have a little bit of time. I've just lost it. Here we go. So for older people in particular, Luke, is it possible that the symptoms for long COVID could have been underreported or undiagnosed in older patients in contrast to the working age population? So any reflections on that? Thank you.
Short answer is yes. I think there was concern around residents of nursing or care homes, for example, who perhaps wouldn't be able to express themselves or have the chance to report their symptoms in the same way. And I think a lot of these things, as the question alludes to, does depend a lot on both activity before acute infection and the ability to let people know about changes as well.
And to all of you, maybe Ahmar, you might have thoughts, but others as well. This question does concern me slightly because obviously some of us are involved in this. But given your research, what advice would you have for the Scottish Government in preparing for future pandemics? Thank you, Ahmar.
I think the most obvious thing would be that people need to be upfront and clear and transparent because they do publish like these reports, but when you read it, sometimes they try to give usually a rosy picture, but might not be a reflection of reality. And what it does is it mismanages expectations. So if you want to manage, which is important, to manage expectation, we have to be really, really clear. So the Scottish Government needs to obviously put in resources, improve efficiency, but on top of it, they really, really have to be transparent. And I think that would be my most obvious thing. And they should work closely with the NHS so that the targets they set, they are realistic, and make sure that they make funding, etc., available.
Great. Gwenetta, last word from you on that question. Thank you.
Oh, last word. I think that it's going to be important that everyone in society is considered when policies have been put in place. If nothing has been more highlighted during the pandemic was that certain communities were not considered during the decision-making process. Refugees and asylum seekers in particular were definitely not sitting at the table.
Thank you. Well, please join me once again in thanking all the showcase presenters.
Good afternoon. I'm Professor Julie Jacko. I'm the Chief Academic Officer of the Usher Institute and the School of Population Health Sciences. It is my great pleasure to introduce our keynote speaker for this year's Usher Annual Lecture and Showcase, Dr. David B. Nash. Dr. Nash is a board-certified internist and the founding Dean Emeritus of the Jefferson College of Population Health at Thomas Jefferson University in Philadelphia, Pennsylvania, where he continues to serve as the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy and Medicine. This year marks his 35th anniversary on the Jefferson faculty, a remarkable milestone in a career defined by leadership, scholarship, and impact. David is widely recognized as one of the pioneers of two transformative movements in modern healthcare: improving the quality and safety of care and advancing, indeed, a pioneer of the field of population health. His influence has been felt globally through his teaching, writing, and thought leadership, and he continues to shape the conversation on how we deliver better, safer, and more equitable care. Beyond his professional accomplishments, I want to share something more personal. David is both my friend and professional colleague. I have witnessed firsthand his remarkable ability to connect with people and to champion others. No one has a Rolodex like David Nash. And what makes him extraordinary is that he shares it freely and without reserve. He is one of those rare academics who measures his own success by the success of those around him. And he does everything within his power to lift others up and to help them thrive. He has also been a trusted voice in governance, serving on hospital boards and with Humana, and he has shared his expertise on stages across the world. His work has been recognized with numerous awards and honorary degrees, reflecting the global reach of his ideas and leadership. And while his professional accomplishments are extraordinary, I also wish to acknowledge the personal side of David's story. He and his wife, Dr. Esther Nash, who is also here with us today, have been married for 45 years. Together, they've raised 3 children and now have the joy of 3 grandchildren. That balance of professional excellence and personal commitment is part of what makes David such a compelling and grounded leader. We are truly fortunate to have him with us today. Please join me in warmly welcoming Dr. David Nash to deliver our annual lecture.
Wow, right? So Julie, thank you so much. What a treat to be here. I'm very glad that Esther was able to join me and she got to hear that introduction. I'm sure I'll have a high price to pay for that later today. Well, fantastic venue that we're in, and this is my first visit to your amazing country. And it is true that starting tomorrow, our vacation will begin and we'll get to have a quick tour, but everything about it has been just spectacular. Special thanks to the whole team, Laura Marshall and many other amazing people, and Professor Sudlow, Professor Bauld. I mean, we just have felt that to be so well treated and just unbelievable. So how about another round of applause for those 4 presentations too, because really, you guys, you set me up pretty good for the topic at hand. So let me try to frame up the subject at hand is post-pandemic population health in the United States. So I'm going to try to do 3 things in the limited time that we have. First, a little bit of vocabulary, and context and history, and you did a great job framing that up for me. But basically, a better understanding of the tension that we have, especially in America, between the public accountability for our $4 trillion a year of spending on healthcare and the professional autonomy that we have as physicians, nurses, pharmacists, and researchers. So part 1 of our time will be a little bit of a review, context, and history, and again, you had a great setup from these 4 presentations. Part 2, as Julie noted, we call it population health, and by the way, you know, coming to Scotland and learning that our 18-year-old College of Population Health sort of is very humble in light of what you have accomplished over decades here is really spectacular. So I'll spend a little time, what do we mean by population health? And a little bit of this is our differences in understanding, and give you some pragmatic approach and even a little bit of evolution of where we think population health is going in the US. And then finally, there's no future in predicting the future, but I'm going to look into my cloudy crystal ball and give you my sense of where we're going as it relates to our attempt to improve health and deal with things a little bit like artificial intelligence and related technology. So quick review, part one, context, history, how did we get here? What is all this anyway? Part two, what's population health and how is it evolving? And part three, a brief look into the future. So first of all, I think we need a geography lesson. So this is my office in downtown Philadelphia. So Philadelphia is the founding city of our great country, right? It was our original capital. My office is 4 blocks from the Independence Place, where the Declaration of Independence was signed. It's where the Liberty Bell is, where Constitution Hall is. So we're very proud of our very modest history compared to the building and the city and the great country that we're in. But in America, Philadelphia is considered a city filled with history. And my office is just a few blocks walking distance from aspects. And I think a lot about what the founders went through now almost 250 years ago. And we're coming up on some very important birthdays in our nation as well. This is a picture of our building. It doesn't have a name. It's called 901 Walnut Street. Perhaps we could get the Usher family to consider a donation and change this to the Usher building on the campus of Thomas Jefferson University. I think that would be spectacular. Jefferson is a delivery system, that's our jargon in America, composed of, ready, 33 hospitals, roughly 65,000 employees, 14,000 of whom are nurses, and in American dollars, roughly a $15 billion annual budget. That's the delivery system. The university, Thomas Jefferson University, which is deeply connected, is roughly a $900 million operation now, 10 colleges, about 8,200 students. But as Julie noted, since I've been there almost since its inception, our 10 colleges now, when I was on campus originally, we had just 2 schools, under 1,200 students, so I've had a ringside seat at spectacular growth, mergers, acquisitions, a typical American higher education story. Our College of Population Health is one of the newest of the 10 colleges, officially voted into existence by our Board of Trustees in 2008, and we entered our first students on September 9th, 2009. 9909 makes it easy for an old professor to remember what was opening day. So public health and population health in America has been a kind of a sideshow. As you're all well aware, graduate medical education, undergraduate medical education, the technology of healthcare in America is the envy of the world. People come from everywhere to study the medicine in America. But yet, when you look at what we have achieved for the spending, roughly $4 trillion, 22% of the world's largest GDP, even back in 2013, so now 12 years ago, we were not really paying close attention to the outcomes of that spending. And it's very heartbreaking for me to report to you that even 12 years ago, we knew way before COVID that we were in trouble with regard to the balance between all of our spending and our ability to achieve health. Because when you think about it, what is the business that we're in? And healthcare in America is the biggest business at nearly 12% of the GDP. So when you think about spending and outcome, there's a disconnect. And I won't go through all the details except to say, sadly, we do not rank in the top 10 of good health outcome in any of the major OECD measures of the health of a population. cancer survival, control of high blood pressure. You give me the measure, and sadly, our great nation, despite our incredible spending, hasn't achieved the kind of outcome that I think any reasonable, educated person, especially within a school of population health, would ask for. Well, this is not new news, and lots of very smart people have been writing and speaking about this for a long time. I don't expect that anybody's read all of these books, but just to give you a little sense of the history and context. So people like Bobby Pearl, who's a very well-known physician leader in our country, had been the medical director of our largest delivery system in the private sector called Kaiser Permanente. Many of you maybe recognize the middle book, Ezekiel Emanuel, largely attributed as the author of Obamacare. Let's go back to March of 2010 when Obamacare was passed. And even Dr. Elizabeth Rosenthal, an emergency room physician turned Pulitzer Prize-winning New York Times investigative reporter who decided to devote the rest of her professional life to trying to understand, ready for this, medical billing in the United States. So these are just 3 books that all pre-COVID added to the conversation nationally and certainly at our college about stimulating questions about what exactly is wrong and what's this connection between what we spend and the outcomes that we get. Well, my 4 colleagues here did a great job talking about COVID, and we're not here to further depress the audience and think about the impact of long COVID and all the rest. But a very sad headline from the Sunday New York Times. So our great country suffered really quite dramatically during COVID for many of the structural challenges that the colleagues reviewed, and I'll go over again in a moment. So we had more deaths per capita than any nation in the developed world. So how do you frame this up in a country that spends 20% of its GDP, $4 trillion? How could it be that we had more deaths per capita than any other developed nation? Well, a lot has been written about this, including some of my own work, but I think there's a couple of take-home lessons. Esther and I were very fortunate to travel to Australia just a few months ago, and it just so happens there's some wonderful work in the New York Times also about Australia and how they did with COVID, and I can summarize what the Aussies think and how they persevered, and it's probably quite similar to here in Scotland. So it turns out that in the review of their performance during COVID, the Australian researchers and scholars, just like this audience, they said there were 3 characteristics that helped Australia do such a good job. Certainly geography and isolation as an island helped, no question, but they are not on the list. The 3 things the Aussies talk about, and I want you to listen carefully in your knowledge of our country as compared to these 3 characteristics. One was the trust that most Aussies had in their government at that time. I'll just let that lay in the air for a moment. The second is their trust in science and in their centralized, like yours, their centralized national health system. And finally, a characteristic the Aussies call mateship, M-A-T-E, mateship, meaning you're my mate and I'm your mate and we're here to help one another. So trust in the government, trust in science, and mateship. It would be a fool's errand to hold this list up to the United States of America in September of 2025, as we don't share those characteristics, not even close. So my response at a very personal level to COVID, not only being worried about our physician daughter and our country, but my response was to write a book. That's what old professors do. And this was my cathartic exercise in working with a fantastic Princeton-based science writer, my colleague Charles Wolforth. So for 2 years, starting in the summer of 2020, August of 2020, you could just remember what was going on back then, Charles and I, and the help of a group of medical student research assistants, decided that we would try to quickly catalog not only all the bad news of what was happening, most especially in America, but then make some recommendations as to what could we learn from this disaster that we might carry forward. Very similar in part to the 4 prior presentations. So let me try to summarize what we learned, and then I'll juxtapose aspects of this in part 2 and part 3. So I think you could, 3 characteristics that really stood out for us in America's response to COVID were uniquely American. And those were, as different from the Australian list, these uniquely American characteristics was our, what we like to call, rugged individualism. We sometimes all believe we're still in a covered wagon, heading out west. We're fighting the Indians. We're conquering new territory. We really value our individual freedom, sometimes to the point where it's harmful at a greater population scale. So one is rugged individualism. The second is American exceptionalism. And here I am in your great country to say that America really doesn't care what the rest of the world does, especially currently. And when it comes even to medical care and science, well, we care a little bit more, but basically we do have a sense of if it's not invented here, well, how good could it really be? And third characteristic is American federalism. And it's a little complicated here in Scotland, but you have to appreciate we are a gigantic landmass with 50 states and 50 governors, each one of whom thought he or she was in charge of the COVID response. And we had some most unfortunate incidents of one governor calling out the National Guard to protect ventilators at an airport so that another governor couldn't get them. So American individualism, exceptionalism, and federalism, you could argue, certainly didn't help with regard to our, tackling this once-in-a-lifetime dreadful pandemic. But let's dive a little deeper into the structural issues, some of which was alluded to by my colleagues. So this is a paper from one of our top peer-reviewed policy journals. Let me summarize. In the year prior to COVID, calendar 2019, America, on average, spent 10,000 American dollars per person, including children, on the delivery of healthcare services, and $450 on support of the public health infrastructure. What more do I have to explain? 10,000 American dollars to receive services with very little measured impact on the health of the population as compared to the rest of the developed world, versus $450 per person to support our public health infrastructure. And this audience, better than most, knows you cannot have public health without public trust. And so these kinds of concepts came to light during COVID. Not only was it a spending issue, but I want to also recognize from the podium, of course, the deep structural racism that our country doesn't really want to confront, but COVID shined a spotlight on these challenges, most especially in our biggest cities, where the disproportionate death rates in people of color really still are undergoing further evaluation. Just to give you one example, drive this point home, in our largest public health school system in New York City, 1 out of every 200 New York City school children in grades 1 through 12 lost a significant adult caregiver. In other words, they died from COVID. 1 out of 200 students. In a school system with over 1.2 million students, that's a significant burden from which we are still recovering. So in the work for our book, and certainly Charles and I were not the first people to say there's a structural challenge here, but I think what did come from COVID, and certainly we spend half of the book, the depressing first half of the book, talking about the scandals that were right in the front of our face. The fact that many authors and policy researchers described healthcare in America as an engine of inequality. Or in this particular Wall Street Journal cover story, how do we fix the scandal that is healthcare? So that's a lot of bad news. Let me summarize. So COVID shined a bright light on issues that we knew a lot about going back, as I told you, to 2013. And certainly, I'm not the first author to point these out. But in the immediate COVID era, and in subsequent books by lots of folks, it's become clear that we have an opportunity then to learn from that era, let's call it a 4-year era, and make some changes and maybe reorient our system to deliver on its promise of delivering improved health. So let's talk a little bit more about the history, because as Julie was so beautifully in that nice introduction, not only is population health a big part of our interest in our college, but so is improving at the bedside the quality and the safety of the care we deliver. So let's try to engage with that concept and then close out part 1 of our time together. So everyone here can read. This is an exact citation from a formative document that's over 100 years old. If you have good eyesight, you could see in the lower right. This is a citation from the inaugural meeting of the American College of Surgeons. Of course, we think this is the modern era, but at this fantastic school, and the history of medicine, I feel, is waiting right on my 2 shoulders here. But you could read along with me. All delivery systems, that's our term for hospitals now, all delivery systems like Jefferson are accountable to the public for their degree of success, and if this initiative is not taken by us, everybody in this room, it will be taken by the lay public. And this is what I alluded to 15 minutes ago as the struggle between professional autonomy. We know what we're doing, we're experts, just ask us, versus public accountability for $4 trillion in spending. So this is a fantastic citation on several levels. First of all, the fact that it's over a century-year-old, the fact that surgeons were thinking about this issue from a primary care doctor's perspective is quite amazing to me and to Esther. That's an inside medicine joke that doesn't really work in Scotland, but that's okay. So here we are, a century ago. Just after this organization was founded in New York in 1918, a very famous Boston Brahmin surgeon was working at Massachusetts General Hospital, probably our preeminent academic medical center on the banks of the Charles River in Boston. And his name was Ernest Codman. Perhaps you've heard of Dr. Codman. Dr. Codman is considered now to be the great-grandfather of the modern quality and safety movement. You'll see where I'm going with this in a moment. Dr. Codman had a great idea. At the end of every surgical procedure, he would write down on a file card how he could have done a better job. So colleagues, just think about this for a moment. It's 1920, 21, 22. Codman is working at the most famous hospital in our country. And he's looking in the mirror and he's practicing self-evaluation, a cornerstone of the modern theory of quality improvement. And he was writing down how he could have done a better job as an expert. So he brought this list of improvement ideas to the members of the Massachusetts Medical Society, also in Boston, the folks who published the New England Journal of Medicine. I'm sure you're familiar with that journal. The reaction of the members of the Massachusetts Medical Society to Ernie's list of how to do a better job was to ban Dr. Codman for life from membership in the medical society. Despite coming from a Boston Brahmin family, scion of a large fortune, Ernie died a pauper on the eve of the Second World War in 1940 and laid in an unmarked grave somewhere in Cambridge, Massachusetts. It wasn't until 2014 that the then chairman of the Department of Medicine at Mass General Hospital, Dr. Andy Warshaw, took up a collection from his peers to find Ernie's plot and erect a proper tombstone. So I like to tell this really remarkable story. It's a very compelling one. This is the origin of the movement of improving the quality and safety of care in our country. Dr. Codman's name is attached to our highest award, the Codman Award, for improving the safety and quality of care. Now let's see if we could bring these two themes. What have we learned from the pandemic, and what have we learned from population health and quality improvement? And let me finish part one, lay out the rest of the challenges, and then let's look at population health as a potential fix for this complicated problem. So what have we learned? Well, in our research at Jefferson and elsewhere, I've been talking about 3 words that characterize American medicine for the last 35 years. And these 3 words are right up here on the screen, called unexplained clinical variation. Now, the physicians and nurses and pharmacists in the room know exactly what I'm talking about. Let me see if I could open this bottle of water. Great. So what I'm really saying is something akin to this. Well, I went to the University of Edinburgh School of Medicine. I had great teachers. I know exactly what to do. Well, I went to the University of Rochester School of Medicine in upstate New York, and I got a great education, and I know exactly what to do. And in an expert-based culture, where there isn't too much self-evaluation, closure of the feedback loop, a national database on what's the right answer, and until we get to part 3 and talk about the future of AI, most physicians, nurses, and pharmacists, but mostly led by doctors, we're going to do exactly what you taught us, because we're convinced that we are doing it correctly. So this unexplained variation, which is a very polite way of saying doctors do what we've trained them to do. It's not a nefarious plot. They're not bad actors, typically. So unexplained clinical variation in a nation that spends $4 trillion, what's the outcome of this kind of behavior? Well, it's illogical to assume that everyone is doing it correctly. Or if you don't accept that, maybe you would accept, but maybe we could do a better job, reduce waste, save lives, redirect resources, improve health. So I think the challenge here is it's a challenge to lowering costs, it's a challenge to improving quality, and it's a challenge to establishing accountability. Another unique thing about America is illustrated by this cover story from Business Week magazine. So take a look at this for a moment. It's a little bit of a disheartening cover for sure. I'll stand back so you could sort of get the full effect here. So medical guesswork from heart surgery to prostate care, the medical industry knows little about which treatments really work. So only in America is half of all spending on healthcare driven by where we work. Employers pay for half of all healthcare in our country. The federal government pays for the other half. This is a unique historical accident. Details for today, not important. But this unique payment scheme means that where we work, those individuals, those employers, have a big say in how money is spent to pay for health insurance and pay for healthcare services. Well, the folks who pay the bills, they're, if you would, they're on to us. First of all, they understand a little bit about this unexplained clinical variation. And since they're spending so much in many companies, more money on healthcare than on the core resources and the raw materials to build the business, again, a uniquely American experience, this combination of unexplained variation and employers playing a role and issues about improving quality, this too came to a head during COVID to say, my goodness, well, we have to figure this out. It's an unsustainable spending curve that we're on, yielding outcomes that really ought to be much better than they currently are. Finally, in this part one together, one other sad thing. So everywhere but Jefferson in Philadelphia, America has a quality and safety problem. And now I'm being tongue-in-cheek, of course. But sadly, if you go back to work in the late 1990s, when we finally understood the scope and depth of the quality of care issues, how we could do a better job to improve, my former student, Marty Macri, now our FDA commissioner and a very important person in the bureaucracy of delivering health care in America, he was one of the first to analyze this data and said, shockingly, in this Lancet paper, that medical error, at least in the United States, could be construed to be the third or fourth leading cause of death. During COVID, of course, COVID eclipsed this, as is illustrated in this slide. But in follow-up research by a team at Harvard Medical School, by follow-up research just a year or so ago, I am very sad to still report, despite Ernie Codman a century ago looking at this issue, if you are over 65 years of age in America and you're hospitalized, you have a 22% chance of having an untoward outcome, that's a bad thing, from being hospitalized, at least according to the best research team, David Bates and his crew at Harvard Medical School, in the lead article in our leading journal 1 year ago. So we still have a lot of work to do. Let me try to tie this all together then into one chart. So the experts believe of the $4 trillion that we're spending, about 1/4 of it is of no value. My goodness. Do you know an organization with a budget of $4 trillion where 1/4 of it is really of no value? You know, I'd be hard-pressed to think of one. So we have a real challenge, and we describe this waste in lots of different ways. A little bit maybe of help here. It's a sort of a staggering thing. There's behavioral waste, and I'll illustrate that to you in a moment, because America is the world's fattest country. Also, we have the clinical waste. I would argue that's unexplained clinical variation, unnecessary testing, trying to come to the appropriate diagnosis. It's a complex notion, but again, not everyone can be equally right. And then administrative waste, which has an awful lot to do with computers at the bedside and the complications involved in trying to handle virtually thousands of different ways we pay for care in America. Let me summarize. The take-home message is it's a wasteful system, staggeringly so. Post-COVID, and our spending continues seemingly unabated. And the message then of $1 trillion of waste means it sets us up for an opportunity, and let me jump to the next slide. It sets us up for the opportunity to re-examine in the post-COVID era the idea of maybe population health is the answer. So here we are in part 2 of our time together. We're right on schedule. And I thought it's best illustrated by this wonderful photograph. I wish I could take attribution for making this picture. So here is this hapless, we would call it a resident or fellow intern, pick your term. And he's precariously balanced between these two canoes. On your left is the way we historically pay for care in America. We call this private practice fee for service. You come in, I deliver service, you pay me. Very different from what you're mostly accustomed to. Versus the notion of some kind of value-based payment. This is a jargon term for sure, but it means maybe we'll pay you if you achieve a good outcome with us and for us. We've summarized this in our college. We call this no outcome, no income. No outcome, no income. Balanced between a world of it doesn't really matter what the outcome is, we're going to pay you anyway. So maybe population health is striking this precarious balance. Or maybe it's just he's going to end up in one of these canoes. Here's what happens. If he ends up in the private practice, historical, and current way we used to do business, he gets in that canoe. 100 yards downriver is a 1,000-foot waterfall, and he is going to perish. Second choice he has is he could jump into the drink and call it a day. We have seen an unbelievable rate of retirement among senior physicians of both genders in the United States post-COVID at a rate no one had anticipated. Basically saying, I've had enough of this crazy system. One more tuition payment and I'm out of here. That's not a good notion in this country. One more mortgage payment and I'm out of here. And then finally, what do we mean by these tenets of population health? Well, let me draw you a map and try to illustrate this, and again, building on the great comments from my 4 colleagues. So this is a schematic drawing of downtown Philadelphia. My office is essentially at the center here, like at the center of this bullseye. And this is to illustrate, using publicly available data, the structural challenges as it relates to healthcare in America's founding city. So if you're fortunate enough to be born in a section of our town called Society Hill, you have a lifetime expectation to live to 88 years. 88-year lifespan. If you get in a taxi with me from my office at that center of the diagram and take a 4-mile ride north, let's call it 25 minutes in the taxi with traffic, your life expectancy is 68 years. So in one city, 5 miles apart, we have a 20-year disparity in life expectancy. Now, maybe some of you don't find that shocking, but let me add a little bit of color back to this. This is in a city where we have 5 medical schools, 2 of which are walking distance from one another. Those 2 happen to be our sister school, the Jefferson Medical College, Sidney Kimmel Medical College, and another university, Drexel University. Together, those are the 2 largest private medical schools in all of America. So healthcare is the biggest business in our city, and our city is characterized, from a population health perspective at least, by a 20-year disparity in life expectancy just in a 20-minute taxi ride. So I would argue that population health at its very essence is trying to reconcile how could this be true? And how do we reorganize resources and reapply our great knowledge in a city devoted to healthcare and healthcare education to fixing this mess? Well, let's go to a very important journal in our country, the daily newspaper called USA Today. This is probably our most important medical journal, most widely read. And I like this because here's the date, February 27th, 2017, so 8 years ago, pre-COVID, when it first became sort of common knowledge, 7 years after Obamacare, right? March of 2010 to 2017. So we've been at Obamacare already 7 years. And here's a front page story that says, hospitals look to profit by keeping patients away. Well, how could that be? Don't we only make money when they're in the bed? So the notion of being accountable for the care we deliver, to get paid to keep people healthy, these were all the core concepts built into Obamacare, which was severely tested during the pandemic. So here we are now in 2025. Our school, as I alluded to, opened back in 2009. We've been at it 16, 17 years now. If you look back at the cornerstone definition of population health, here it is in a famous paper from 2003, 22 years ago, when David Kindig and his colleagues at the University of Wisconsin said, well, it's not public health that's going to save us, it's population health. Now, we're not dismissing public health, we're internalizing it within the definition. And here are the cornerstones, the basic sort of key definition of population health. And I'm not going to walk you through all this except to say, wow. So population health says it's not just morbidity and mortality and quality of life. It's this other stuff. It's socioeconomic status. It's genetics. It's choosing your parents wisely, if possible. That's important. It's your social environment. It's all these social determinants, many of which were articulated by the 4 prior presenters. So what's the message? Well, when you really boil it down, here's what population health, at least in its current definition in America, is all about. On your left is what makes a society healthy. It should be no surprise to this learned group that, well, a lot of it is individual behavior. Stop smoking. Drive with a seatbelt. Get your vaccines. These are the tried and true public health attributes that improve health. Clean drinking water and all the rest. A clean environment. And a tiny bit of it, probably 10 to 15%, is testimony to fantastic medical schools here in Edinburgh and at Jefferson. But the truth is, in America, the spending is all upside down and backwards. As you could see on your right, that 88% of spending for improving health is on the actual delivery of medical services, with precious little going to changes in behavior, nutrition, exercise, bike lanes, promoting health at the workplace, criticized by our national characteristics of individualism versus what's often called the nanny state. I'll drink as much regular Coke as it pleases me, essentially. So we have a conundrum. So remember the list of the different types of waste: clinical waste, behavioral waste, administrative waste. Here's another way to think of the behavioral component, and let me show you this, one of my favorite slides. So of course, this is Michelangelo's David circa 2025, not the one in the Uffizi Gallery in Florence, Italy, for sure not. But I'm going to use this photo, and glad it got a giggle here, to ask you a question. So based on research going back to 2006, which has subsequently been verified twice, one in 2010 and a second time in 2018, 3 different organizations in America looking at this issue, so I'm pretty confident in the data. I'll ask you the question and then we'll get the answer together. So what percentage of adult Americans, people over 18, do all 5 of the following behaviors, generally speaking? Exercise 20 minutes 3 times a week, don't smoke cigars or cigarettes, eat their fruits and vegetables like their mother taught them, wear a seatbelt, and we'll give partial credit for number 5, are close to an appropriate body mass index. So one more time: exercise, eat right, don't smoke, wear a seatbelt, and try very hard to control your weight. So what percentage of adults do all of these behaviors currently in America? Let me give you a drum roll. And the answer, of course, is 3%. So here's another challenge, colleagues. Balancing $4 trillion a year spending on the greatest medical technological infrastructure in the world that doesn't deliver necessarily health. Let's juxtapose that to those behaviors, going back to American individualism, federalism, exceptionalism. This is a toxic brew. So it's a real challenge when you think of it from a behavioral point. Now let's bring it down to medical education level, the challenges we face in a college of population health. What sort of formal training do most physicians in America get on nutrition, exercise physiology, behavioral economics? The answer to that question is very, very little. And so the notion of how do we change societal behavior, there's a whole field, of course, of behavioral economics, a lot of it coming from our a highly competitive sister school at the University of Pennsylvania. Details for today we can't cover, except to say, wow, 3% strikes me as a low number, but the evidence behind it is pretty significant. Okay, the good news is, led in part by our college, we created the first ever textbook of population health in America. And again, I am very humble standing here knowing that members of the Usher family, their DNA is in this room, which is incredibly exciting. And that Professor Gould is the Usher Professor of Population Health is really quite remarkable. So we were very proud to put together this edition. The 4th edition will be out in January of 2026 in time for the new year. I am very proud to tell you that I've been the editor-in-chief of our only peer-reviewed scholarly journal in the field in America, Population Health Management. Julie was an original member of the editorial board of this journal, and it's how we originally met. So will scholarship and training of a new cadre of leaders move the needle, improve health? Well, I sure hope so. That's what old deans are all about. But I want to shift gears a little bit and give you some more pragmatic, as promised, information about where I think population health is going, and then we'll quickly turn to Nash's view of the future. So first, we need a geography lesson. I was concerned about doing this, but you're super smart. You'll figure it out. So this is a picture of the great state of Pennsylvania. Now, Pennsylvania is a big rectangle, and most of the population is in 2 major cities. One is Philadelphia, which is right here in your lower right, and the other big city is Pittsburgh, which is sort of in the middle of the western part of our state. So Pennsylvania is an aging state, probably among the most, has the population that is the most aged. Probably 2 or 3 states may top us, but basically we're a very old state from a population perspective. The state is comprised of 67 counties. And using publicly available data, the Robert Wood Johnson Foundation and others have essentially ranked all 67 counties in our state from most healthy, number 1, to least healthy, number 67. Everybody with me on this? Yes? Good. So I want to call your attention to number 67 out of 67, essentially dead last, is the county of Philadelphia, home of those 5 medical schools, including the College of Population Health at Jefferson. So what's population health? Reconciling this mess. How could it be that in a county with unbelievable resources, our population outcome measures place us dead last in the state? So let's shift the conversation then. Well, what's happening, especially post-COVID, to try to implement the concepts of population health in a uniquely American way? So, of course, the question we ask is, well, how do we make money practicing population health? Because if it doesn't generate revenue, it just ain't going to happen in America. So it's a complicated answer, and I'm going to try very hard to summarize it for you with just 2 or 3 slides. So for the doctors and the leaders of the delivery systems in the room, it's a complicated answer because here's what we're going to have to do. And I won't read all of it, but I'll give you a flavor for what the pragmatic approach to population health moving forward to tackle the challenges we've just been speaking about. What will it look like? It will have several flavors, including utilizing predictive modeling, great, what you guys were working on, assessing risk for the organization, managing utilization, that tries to get at unexplained clinical variation, optimize efficiency and costs, awfully hard to do, improving the patient experience. Basically, you know these concepts, but this is all part of what we're struggling with from a pragmatic perspective to try to take the tenets of population health. Who needs to be seen and why? Maybe we could combine the power of artificial intelligence. I'll show you some of this in a moment. Maybe we could realign the economic incentives to actually drive improvements in health. We've actually been doing this for decades, but there's much more, I think, of a public mandate now to at least attempt to do that. Jefferson has taken yet another step, and here's a cover story of a magazine we talk a lot about in America called Modern Healthcare. And maybe you've never heard this term, that's okay. We've seen the creation of a payvider, again, a uniquely American thing. That's an organization that's providing care, like a hospital, and also an organization that's paying for care, like a insurance company or a managed care company. Don't worry about the vocabulary. Main message, a new type of structure that's really in business to align incentives so that doctors, nurses, pharmacists work together as a team and begin to ask more questions, just like Dr. Codman did 100 years ago, to say, how could we do a better job? Maybe we need teamwork. Imagine that. Maybe we need training on systems thinking. Again, bringing together the concepts of population health, the concepts of improving the quality and safety of what we do. This will mean changing the training paradigm, moving away from a dogmatic see one, do one, teach one approach, or in so many cases I have seen, you know, when a senior registrar says, in case after case after case I have seen of this, from a population health perspective, colleagues, that's an N of 3. So you should ask the registrar, excuse me, in God we trust, all others provide us with their data. So maybe a payvider is part of the answer. So let me skip ahead, because the other pragmatic aspect here, we're seeing the development, clearly only in an American way, of 2 new industries to aid in this potential transition. One industry which we've done research on, we call the value-based care industry. I'll show you a picture in a moment. The second industry is the social determinants of health industry. And here, hot off the presses, is the first ever picture of these new industries. And most of these names you've never heard of, that's okay. The main message here is, from a pragmatic perspective, the evolution of population health to change incentives, to reduce waste, to improve health in a uniquely American way is to have private sector money to support the creation of new companies that will help the delivery system to potentially achieve these new goals. And here are some of the companies. It's a fascinating new area. If we had more time, I'd go into the details. But I wanted to leave you with the sense that there's an awful lot of energy, perhaps more heat than light, being generated currently to tackle this challenge in our country. Finally, to close out part 2, the good news is, from a national perspective, we get the issue about equity. Despite the current administration and the current cultural challenges and polarization that we face, within the healthcare industry, America's biggest business, we're committed to finding a way to hold the delivery system feet to the fire, to improve equity, to reduce structural racism and all of the other social challenges where possible that we could tackle. In fact, to make this even more personal, I'm involved in work with Dr. Jacko's husband, who's a professor of health administration in Florida, and he's part of a grant looking at exactly this issue called the Equity Index. Details not important. What this is a $1 million grant from a non-governmental agency in Southeast Florida charged to the University of Southeastern University to say, find a way to get hospitals to work together in Southeast Florida to tackle these issues. Okay, Let's get to the final part of our time together. And again, this is a cultural photograph. Let's see if it translates. So this is a deer caught in the headlights. Now, that is an American expression. It means it's a surprise that you know, how do we deal with this? So I hope you'll resonate with it. And as promised, very quickly, the last part of our time together, I'm going to do a quick summary and make 2 or 3 predictions about the future. So let me summarize. For the last almost 45 minutes, it's been so much fun to be up here, a wonderful setting with a wonderful group like all of you. What have we learned? Well, let's go back to 1918, basically, because the past is the present, always. So we've learned that it's still a battle about transparency and accountability. All those new companies trying to improve health, creating a value-based care industry, a socially determined industry, to move gigantic delivery systems like Jefferson's in the right direction, realign economic incentives. Will we be able to do it? Well, I sure hope so. I'm only going to have a ringside seat now, not one actually in the ring. So I can only sort of, call it like I see it instead of being in there getting a bloody nose. But I sure hope we have the wherewithal. Do we have the moral authority and commitment? That's another question. But I do think if you look at the arc of history in our field, this notion of transparency and accountability, and as I said previously, the idea of no outcome, no income, I hope it will get us there. Of course, everybody in this room knows the real challenge is changing the culture, right? And that is the toughest thing because culture will eat electronic medical record for breakfast. So how do you change the culture? Well, this is just Nash's list. I'm sure you have your own. One is practice based on the best available evidence. Well, speaking as we are in this great hall from this great school that created so much of the evidence, if you could find the evidence and then apply it, especially as we're making decisions at the bedside, that would be awesome. Reduce unexplained variation as a byproduct of practicing using the evidence. Reduce adherence to that professional autonomy, awfully hard to do. Continuously measure and close that feedback loop and give doctors good information in a timely way, in a non-punitive way about how they're doing, and then get out of their way. Because generally speaking, they'll stampede to improve. And then, of course, for the future, engage with patients. And everybody under 35 years of age in this room, I'm talking to you. Because for Esther and me, it's already too late. For all of you, engaging on your phone, doing telehealth anytime, anywhere, using ChatGPT 4.0, it's going to be an entirely new world. You will be a direct participant, potentially even a co-decision maker. It's going to be an incredible challenge from a delivery system perspective, but from my perspective, wow, how exciting. So, it will require a new type of leadership. That's part of the reason we built the College of Population Health, because in America there was no sort of place you could bring together quality and safety and health economics and the tenets of population health to create leaders for the future. I think one of the challenges we have, and perhaps you have it right here on campus, is this. Well, for the first time in the United States, we have 4 generations at work at once. This has never occurred except in the post-World War II era. So only in the last 80 years do we have 4 distinct generations at work. You can see this great picture. The boomers, that's me. Generation X, the millennials, that's my children, and Gen Z. So the silent generation, they're largely retired, and Gen Alpha, God help us, they're not in the workplace yet. But those 4 generations at work, they have a totally different worldview. Their behavioral characteristics are different. Their respect for authority is different. And I know you don't call them faculty, but we do. So in the last year of my 11-year tenure as dean, I had numerous very accomplished assistant professor and associate professor members of the professoriate say to me, our college is like a democracy and everyone has an equal vote. Well, I'm looking at the leaders to see their body reactions to that. Well, of course that's not true. but they felt in their heart that that was how a college should be run. So these generational challenges, maybe we can harness some of this energy. Okay, in the closing 5 minutes, so I know in our hurried tour with Brian yesterday that he's a telehealth practitioner. I know you've been a leading organization in bringing care into the home. So we're seeing a transformation in what the hospital is all about in America. Leading magazines like the Wall Street Journal are all about the hospital at home model. We'll see if this pans out. I'm excited about it. Certainly, I think with new technology, we'll be able to deliver new services. And let's spend just 1 minute on AI and then conclude. So the AI universe, and I'm not an expert, certainly not, but we've studied a lot of this and its impact on population health moving forward. And this is just a great diagram that I stole from someone about how you rank AI, machine learning, neural networks, deep learning, and generative AI, or now as it's come to be called in the US, agentic AI, where the technology is self-sustaining and self-thinking. So, you know, this is a lot of jargon. So maybe we could make a chart. So here's an easy way to think about AI in healthcare. On your left is what AI is good at, and on your right is what humans are good at. So take a moment. This is from my good friend Tom Lowry, author of a great book called Hacking Healthcare, spoke at our population health meeting in Philadelphia just 2 years ago. So AI is very good at variance analysis, you know this, pattern recognition, automating dreadful, boring work, information processing, agentic AI, the list is a little longer. And we're pretty good, generally speaking, at reasoning, judgment, imagination, empathy, and creativity. So I do believe that we'll be able to sort of improve this list, expand this list, maybe a better word. And the power of AI, especially what America is devoting to the resources to build the machinery, to build the rooms big enough to house the computers, to build enough power source to power the rooms that the computers are in. And I think in the next practice lifetime of our daughter, who's currently a primary caregiver in America, I think she's going to have these tools at her fingertips. So colleagues, let me draw my time to a close. First, again, I want to thank Professor Jacko and the leadership. What an incredible opportunity to come here in this beautiful setting. Let me leave you with 2 or 3 closing thoughts. So as Julie mentioned, it's my 35th anniversary at Jefferson. So for the younger members of the professoriate in the room and for students, how do you survive in one place for 35 years? Well, let me give you a little advice. First, start young, if at all possible. Have a super supportive partner and a great family. That's always really critical. And try to outlive all your enemies. If you can't outlive your enemies, well, you could always put them in a pot and boil their bones. But I think starting early, having great support, outliving your enemies, good advice for anybody. On my final slide, I want to continue to give you all kudos. So among my favorite teachers is John Kotter, who's still alive in his late 80s, a famous Harvard Business School professor. And among a lot of his work, my favorite for today, John was fond of saying that the institutionalization of leadership training, what we're doing here today by honoring the Usher family, by bringing the broader community together, by tackling difficult issues, by having 4 tremendous presentations very deeply connected to our work, by the work of this great university, occupying your brand new building for the Usher Institute, all of that is practicing what John Kotter preaches, right? So to build the leaders of tomorrow, that is the principal responsibility of the leaders of today. And you have all delivered on that promise. Thank you very much, ladies and gentlemen. Thank you. Okay. Did we do good?
We did really good.
We did good. Are we on time? Almost on time.
This iPad is, there's smoke coming out.
Smoke coming out of the iPad. Uh-oh.
I'm just going to launch into these questions.
Go
You
for
ready?
it. We're ready.
Your talk, Dr. Nash, makes it seem as like the current state of healthcare in the U.S. is a sort of accident. But wouldn't it make more sense to think of it as intentionally designed to drive profit at the expense of human health?
Yeah. Wow. So, you know, Julie, when I got to Jefferson 35 years ago, I was 6 feet 2.5 inches tall. And now I need almost a box to stand here before you. Well, you know, sure it could be potentially characterized that way. I reject it. There's just too many smart, dedicated, hardworking people doing their very best to work within a system and in a society that, at least at the moment, is super polarized. Let's just give some examples. So look, at the very beginning of COVID, it's almost too hard to talk about. We had an amazing thing called the incident command. So in America, this is a mandate that every hospital, just like in Scotland, has to be prepared for an emergency. And there's a structure called the incident, that's the pandemic, command structure. So Charles and I studied this, and what did we find? It's really remarkable. It took a pandemic for people to really come together every day to say, how can we do a better job? What can we learn from another place? At Mount Sinai, they're doing this, and at Jefferson, they're doing that. Who's doing it better? Let me call a friend. Let me call people in Italy. Let me call people in Australia. So we rose to the occasion. And what I'm hoping is that with some of the new tools and with potentially a better understanding of everything we've chatted about today, I'm still hopeful for the future. I have to be. The glass is half full always, but it is a legitimate criticism.
What's the point of focusing on individual behaviors if we don't address the structural and environmental factors, such as access to outdoor spaces,
Sure.
access to fresh food?
Great. So I would say we have to do both. Let's tell a story, because grown-ups remember stories. So in my training at great places in America to become a primary care general internist, I'm embarrassed to tell this audience, I never once asked in my 30 years of primary care practice, I never asked a patient, did you have any trouble getting here today? Is there food in your refrigerator? I mean, our view, especially at an elite academic center, was quite frankly, that you are lucky to be here. Now, our 3 children, 1 daughter who's a doctor, her training was very different from that. And she, as a matter of routine, was taught to ask those difficult questions, find resources, and I believe in the next generation of trainees across the spectrum, bringing the tools to bear to provide those sorts of resources, addressing the food in the refrigerator, the cost of the parking, the cost of public transportation, those structural challenges, that is our responsibility. And it's a paradigm shift in how we train, how we think. Are we there yet? Certainly not. But even talking about this is a huge advance for us because of the nature of the culture of clinical practice, where we've been in one practice lifetime and where we're going.
Your talk has largely focused on healthcare and hospitals, all of it very interesting. Public health is largely about prevention and communities.
Correct.
So how can the U.S. and other nations tackle the underlying drivers of health that are making people sick?
Sure. So let's look at the list. I mean, again, we're talking about a population where 3% of the 350 million roughly 300 million adults do what we would like them to do from a healthy living perspective. So that will mean changing everything, changing how we subsidize food, how we distribute the resources, what we teach as early as elementary school in healthy eating, putting aside resources for bike lanes, all of that. And again, in a country characterized by individualism and exceptionalism and federalism, it's a continued struggle. The greater good versus the individual need. We will not change that overnight, and it will be a continuous struggle, no question about it. But those are the cornerstones to improving health. It's not more services. That's what we just certainly went over.
And contemplating that premise of the greater good, you began your presentation speaking about the AUSI approach to mateship.
Mateship, yes.
So how does a nation, any nation, not just the US, but others as well, move closer to that premise of mateship?
Wow, yeah. Well, I think that has a lot to do with leadership and culture, but mostly leadership at the very top, setting the right tone. We're open to communication. We're accepting all. Our borders are open. We know that we could grow from diversity. I mean, all the things, sadly, at the moment, again, that we're not talking about in America, that's what made America great. Truly what made us great.
So setting aside for a moment the politics of science and US federal funding, decoupling those for just a moment, pretend for a moment, David, that you've been approached by a major philanthropist, somebody who has the ability to move mountains with money. And that individual comes to you and says, my foundation wants to put immense amounts of money into solving the problem of poor health in the United States.
Yeah, great question.
Right?
And given we have 1 minute left, I'll give you a quick summary. So my view, and I didn't create this, but there's lots of other people who I'm sure would agree in America, reduce income disparity. If you could do that, and there's lots of ways to do that, if you could reduce income disparity, give dignity back, I think that would go a long way to tackling a lot of what we've talked about today.
Thank you.
Great.
And thank you for your great questions.
I stay here for the award?
And we're going to go through
Okay.
Wow. That was fantastic, wasn't it? David, thank you so much. Thank you for your insights, your humility, your honesty, your transparency, your breadth and depth, and for giving us some real food for thought and enticing us into thinking about some of the challenges which face you in the US, which actually face us all over the world in very different contexts, and where it's easy to become complacent and arrogant. It's very refreshing to hear someone talking about a system which they have loved so much that they want to make it better, make it work for their fellow citizens. And we should, I think, all take some lessons from that. Look at ourselves, look at our own country, look at the countries around us, and have a think about what we ourselves can do better to influence population health in our own settings. So, David, just to thank you again for a terrific tour de force. So we have a gift for you here. In here you'll find a couple of items for you and your wife, but in particular a quaich, which is a particularly Scottish gift.
Scottish gift, okay.
And you should take it with you and fill it with the good things that you come across when you go on your tour of the distillery.
Outstanding.
In the Highlands.
Can I put
in fact, fill all of them.
Can I put a wee dram in here?
Well, yeah, you should put a wee dram in all of them, but in particular in the quaich, which is a very fine crystal thing. So
thank you very much.
Thank you very much indeed.
Great.
Thank you. So I have many people to thank, other than David, and so just to rattle through them, I'd very much like to thank as well Professors Julie Jacko and Linda Bauld, who've played such an important part in this afternoon's proceedings. But thank you to Julie in particular, who, for your friendship with David, for your friendship with Esther, and for inviting David and Esther to join us here today, and for all the preparation that I know you personally have put into making today such a success. I'd like to thank our showcase presenters, Ahmar, Nicola, Gwenetta, and Luke. You did an absolutely amazing job. I loved listening to you. You were absolutely 5 minutes, almost exactly, each of you. So thank you for that, because speakers sticking to time is not something that necessarily always happens. So very well rehearsed and very beautifully presented. Thank you very much to Fiona Dobby, our Director of Research, and Stephen Kerr, one of our very talented Chancellor's Fellows here at the Institute, who helped to shortlist the posters in our competition. Thank you to all of those who've presented during the showcase display. Thank you to the Emeritus Professors who are here with us today, Professors Amanda Amos, Jerry Fowkes, Brian McKinstry, and Scott Murray. Thank you to Vision Events, Pegasus Sound and Light, and the University of Edinburgh Hospitality and Events Collection for their help in making the delivery of the event such a success. And thank you to the Usher communications team, so particularly to Laura Marshall, Laura, you've played another blinder today, so thank you very much, but also to everyone else who's been working quietly behind the scenes, and you might not have been aware of everything that Sarah, Kitty, Dawn and Susan have been doing as well. Now, before I entice you with some of the things that will happen in the future, we have a very important presentation to make. So earlier on, those of you who were busy downstairs looking at all the posters will have been aware that there were 5 posters that Fiona and Stephen had shortlisted to be part of our poster competition. And Julie and David were busy having a look and hearing presentations of the material on those posters, and they have awarded a prize. But all of the posters that we saw, and indeed all of the interactive displays, have been amazing. I want to thank the 5 shortlisted poster presenters. In fact, I think you should all 5 of you please stand up just to make yourselves known. And turn around and face the audience. So thank you very much to all of you. But the prize winner, so now I do my metaphorical opening of the Oscars envelope. The prize winner, and I'd like to invite you up onto the platform, is Dr. Suzanne Maxwell. Suzanne.
Great job. Really great job. Tremendous.
Congratulations, well done. I think we need to just stand for a moment, yeah, because we'll just take a little photo opportunity here for the local press and the national press as well.
Thank you.
Thank you. Congratulations, Suzanne. So it just remains for me to remind you of a few forthcoming events. We have very soon, on Tuesday the 7th of October, in another wonderful venue, the stunning Playfair Library, 2 inaugural lectures being delivered as a double act. So Professor Jacko and Professor Stephen Newell will be delivering their inaugural lectures. Please do come along. There's a QR code, hopefully behind me, so you can register for that. If you're one of the professors, you can dress up in coloured clothing and special hats and parade around and look very important as well. So it's a great display of costumery inaugural lectures in this great university. It would be great to hear your feedback and thoughts about this event, so please do take a moment to complete the evaluation survey, and you can access that using the QR code on the slide. If you do it quickly, then it'll save the team chasing you up for your thoughts afterwards, so please do. Thank you everyone who's joined us online, and thank you for continuing to be with us throughout the afternoon. A reminder that the wonderful showcase display which you enjoyed before this afternoon's presentations is still available for viewing for another hour or so, so do feel free to go downstairs and carry on enjoying the displays. There are more refreshments available for you as well, just to entice you and make you feel welcome to stay here. And you get back out the same way that you came in, surprisingly. So via the glass entrance up into Bristow Square that you came in. Do look out for details of next year's annual showcase and Institute lecture, and we will be making announcements about that shortly. So we look forward to welcoming everyone back next year, but in the meantime, thank you to all of you, and in particular, thank you again to Dr. David Nash. Thank you.